Good evening, everyone, and thank you for joining for our monthly appointment with our LEJ Endo, List Endometriosis Journal Club. Today we have Charles Andre Philippe that has joined us very kindly and is gonna talk about IFU and treatment of rectal endometriosis. I'm gonna start with two small papers, but before some housekeeping. This legend has been done together with the European Endometriosis League and the support of Castors. The idea is that we want to share with all of you recent and less recent interesting papers that are around minimal invasive surgery and more specifically around endometriosis. We don't always agree with them, we don't always endorse them, but are papers that are worth mentioning. I think we can start already with our first paper that is going to be presented by Mr. Shane Casali, fellow, and then second paper is going to be Charlie Cutter, which is a resident working in Ashford and St. Peter now, and hopefully a future fellow as well. I think Shane Casali is going to join us later on today.
Okay, hello everyone. It's Charlie. I'm an SC4 working in St. Peter's. I'm actually going to present this paper first, which was published by the Preempt trial group in the BMJ in 2024. So it's looking at the use of long-acting progestogens versus combined oral contraceptive pill for preventing the recurrence of endometriosis-related pain. And it's the Preempt pragmatic parallel group open label randomized control trial. Next slide, please. So in this trial, they were enrolled 405 patients across 34 UK hospitals, and the recruitment started in about 2014, and final follow-up data was obtained in July 2022. So before I go on, just got a little poll for you all here. I hope you can see it on your screens. So post-excision surgery, what is your preference on hormonal treatment to reduce the recurrence of endometriosis-related pain? And please select. I'll give you guys a couple of minutes.
We can see the pool at the end.
Can we see the poll at the end? Fine.
Yeah.
Go it away. And then these patients, these 405 patients, were randomized in a sort of one-to-one ratio to receive either a long-acting estrogen, which is medroxyprogesterone acetate, or a Mirena coil, or the combined oral contraceptive pill. And then the primary outcomes that they measured were pain scores. The pain score that they used in this study was the Endometriosis Health Profile 30 questionnaire, which is, I'm sure you most know, that it's a patient-reported outcome measure used in endometriosis trials. And then secondary outcomes that the authors looked at were sort of treatment failure. So what counted as failure in this study was either having further therapeutic surgery or second-line medical treatment, such as GnRH agonists or antagonists. So in terms of the study demographics, the mean sort of age of our patients in the study were around 29, mean BMI between 26 and 27. All the patients had excisional surgery before starting either a progesterone or the COCP, and in about the majority of patients were considered to have a complete excision as judged by their surgeon after their initial operation. The stage of endometriosis, so the majority of patients actually had stage 1 to 2 disease, because one of the exclusion criteria of this study was basically any patient with plans for elective surgery for deep disease. So it was more focused on patients with more superficial disease. And the majority of the patients in the study were white and nulliparous. Next slide. So in terms of results, sort of 3 years after randomization, there was no significant difference in pain scores between the two groups, with both groups showing a similar reduction of around 40% compared to their preoperative values, which was a good result. On average, both groups maintained improved pain scores at all follow-up intervals compared with their preoperative scores. Interestingly, fewer women in the long-acting progesterone group actually required any additional treatment compared with the COCP group. So it sort of that translated into if you look on the graph on the right, a sort of 33% reduction in time to treatment failure in the LAP group versus the COCP group. And in this study, as aforementioned, treatment was considered to have failed when patients needed either further surgery or when a gonadotrophin-releasing hormone analog were used, or if their EHP30 scores returned to preoperative values. Next slide. So in terms of the strengths and weaknesses of the study, so it was a really impressively large sample size with 405 patients, which enhances the reliability of the findings. It was a long follow-up period of 3 years, so it sort of provides quite good insight into the long-term effectiveness of both treatments. There was a high follow-up rate with about over 80% of patients actually provided primary outcome data, which minimizes the risk of bias. It also focused on patient-centered outcomes, and it used, a patient-focused validated scoring system. Unfortunately, in terms of weaknesses of the study, there are quite low adherence rates. So only actually 30% of patients who were randomized to the depot continued on it, and only 46% of patients continued with the Mirena coil. So this low adherence rate might sort of limit the trial's ability to detect meaningful differences between the two interventions. Additionally, as we noted in the sort of demographics of the patients, the majority of them were white, so it's got limited generalizability to the background population, perhaps, and in the study there was no treatment control group. Next slide. So to conclude, your long-acting progestogens and the COCP are equally effective in reducing the recurrence of endometriosis-related pain in the first 3 years following surgery. But if you want to reduce the need for further intervention, then perhaps long-acting progestogens are a better option.
Do we have a poll from the people to see like what is the preference from the audience? It's quite even, isn't it?
It's quite.
So welcome to more members of CMIC London. We have Mr. Casali that has joined us, and also Avril Baci.
Hello. No, Avril is not here. Avril is, I think, en route to Malaysia. Yes, yes.
I'm just putting this on in the background.
Sorry,
she's here.
Is she here? Oh, okay.
I didn't want to miss it, so I'm just putting this in the background and listening to
Okay.
the
Okay. So don't mind me. I'm sorry. I had to pick up my son. I'm running a little bit late. Okay. Thank you
we
very
just
much,
started.
Charlie.
That's all right.
Dr. Philip, do you have any preference yourself on what do you advise after excision?
Actually, it's interesting to ask the question that way, because I think this study comfort me in what I'm doing, especially trying to let the patient choose the treatment she prefer, and my goal is for her not to have periods, and her goal is to tolerate it as much as she can. So usually I have quite my way of trying pills depending of the stage of the disease, the age of the patient, and then usually it's the patient that choose. But I'm happy to see this low difference, telling me that letting the patient take the one that blocked because I didn't really understand if every patient has no period, how many patients stop because she had bleeding. That's a question that I'm asking myself, which is the one that blocked the period the most, which is the best tolerated, and then the impact on the pain and on the recurrence I would not say it's secondary, but maybe it's like it's the second question I would ask myself when I asking which pill to propose. I don't know if I'm clear or not.
Yeah, absolutely. Like, and then I honestly do the same. I don't really advise one on top other than the another one. I think it's very important for someone to find a contraception with a good compliance that can tolerate well, because consistency is more important from this point of view.
And we don't have medroxyprogesterone. We can have it in French, but it's very, very low. Its use is very, very low. So I cannot really tell you what I'm thinking about it, but we use a lot the IUD.
Yeah.
But I will not say that it would have my preference for deep endometriosis, for example, because I believe that it stays more closely to the uterus, but maybe it's not as true as it could be. So the estrogen progesterone is good for the young woman because the tolerance is maybe a little better, I think. But
by the way, hello, Charles-André.
hello, Shane. I'm very happy to see you.
It's nice seeing you. It's nice seeing you.
Me too.
Okay.
What is your point about
next?
this question? Yeah, next.
Let me just launch this poll and then. Okay, so I'm just very quickly going to talk about this paper, and then Dr. Philippe can present on his HIFU. So this was published in PLOS One in May 24, and it was a systematic review and meta-analysis looking at RCTs that were questioning vitamin C and E taken in combination and how it reduces pain symptoms related to endometriosis. So there's emerging evidence that suggests oxidative stress plays a role in the development of endometriosis, increasing the reactive oxygen species. That in turn increases the inflammation, causes cell damage, and that's what translates to the patient's pain. So the idea between antioxidants is that you're reducing that. There's lots of different antioxidants, but vitamin C and E has the attractiveness that their long-term use has got very limited side effects. So this study group looked at them in combination with regards to reducing pain symptoms versus placebo, and their hypothesis was in fact that the antioxidants reduce the pain compared to placebo. So moving on to the materials, they followed the PRISMA guidelines, registered with Prospero. They did a search on widely recognized search engines, PMC, Scopus, Medline, clinical trials, and they included all RCTs. They assessed the effectiveness of both vitamin C and E together versus placebo in endometriosis-related pain. And then they had two authors independently screen all these studies, assessing their eligibility. And then once they had agreed these 5 studies that were included in this meta-analysis, they compiled all the data in an Excel, and the pain relief measured was done as a proportion of the patients experiencing reduced pain at follow-up. So these were the 5 studies included. You can see that there was a degree of homogeneity in that the study durations for all of them were 6 to 8 weeks. The doses for the antioxidants were similar, with the exception of the Iranian group. They had a slightly lower dose of vitamin E, and obviously they were all RCTs. So going straight on to the results, so they were split up into chronic pelvic pain, dysmenorrhea, and dyspareunia. And you can see that in all of these pain aspects, that there was superiority seen in the antioxidant group compared to the placebo group. So with chronic pelvic pain, the relative risk was 7.3, and in contrast, in the placebo group, with regards to chronic pelvic pain, there was actually an increase in pain score seen at the 8-week mark, although that wasn't statistically significant. With dysmenorrhea, again, there was superiority with the antioxidants, but a risk ratio of 1.96. And then with dyspareunia, it was 5.08. And actually, all of these results were significant, and the heterogeneity between the RCTs was deemed very low, 0%. So
conclusions that this paper drew, that antioxidant supplementation with vitamin C and E, when taken together, reduces all three areas of pain in endometriosis patients. It postulated that this pain relief effect was likely due to the antioxidant's ability to reduce that inflammation, inhibiting pro-inflammatory cytokines, whether it's interleukins or TNF alpha, and by doing so, that neutralizes the oxidative stress and reduces the pain. Limitations: small sample size and a small number of studies included with a short follow-up period of just 8 weeks. They did do a risk bias assessment, and there were some concerns on bias with regards to blinding of some of the RCTs, and as always with these conclusions, further larger scale RCTs are needed to confirm the long-term efficacy of antioxidants such as vitamin C and E.
When we were choosing studies, that really caught my eye, because I don't know, it's such a harmless, simple intervention to do that it just makes you wonder, why not? You know, why don't we just tell all endometriosis patients that have vitamin C anyway? I don't know. What do you think, Charles-André?
That's an excellent question. And I think these two studies point something about what we know and maybe what we never know about the endometriosis, because we always made the mistake of mistaking the endometriosis for its pain, which is maybe two different pathology, two different disease. And the same question can be also asked after you will look at my presentation. And especially if you question me a lot about the future of my presentation, because I actually didn't show you the results of the last one, but I knew some. And to answer you, I don't use vitamins. Exactly like you say, something good cannot kill, but the explanation of giving vitamins to block the oxidation and then the inflammation, I don't buy it a lot. And it's the same for all the regimen the women are prescribed, like the irritable bowel syndrome is something you can treat with diets, specific diets, but it's not working directly on inflammation and COX and everything. So why not take vitamins? Carents are not good, but if you, and especially if you have a diet without carbohydrates and everything, maybe you lack some vitamin, and maybe it's something good to give it, but like.
Can I ask you another question? Do you work with a dietitian or a nutrition therapist generally?
Okay. Yeah, definitively, because the IBS is like maybe in 60%, 70% associated to the endometriosis, and you have to treat that. And giving vitamins because you will maybe have a diet that will not help you to have it in good amounts is something interesting. But today, I just say, as you say, it's easy to give something that is not difficult, that is not dangerous. But I'm asking myself, does it work? Can the fact that 6 months after taking it, you go better, prove that it's because of that you go better? And it's exactly the same thing that you can ask me with the IFU, and I cannot really tell you, because when you try to...
So what with regards to, let's just take vitamin C. We just saw a meta-analysis of how many randomized controlled trials, Flo?
For retain at the end.
It was just 5.
5. Okay. So what would convince you to start giving vitamin C? What would you like to see?
I don't know. The fact is, In my case, we make the randomized trial in HIFU, and we were surprised by the results because both groups were improved. And the problem is sizing the endometriosis by its pain, and for sure you have to do that because it's a painful disease and a functional disease, and you cannot assess it on the survival. But still, the pain is something so complex.
Yeah.
So complex. We made surgery on pain. So that's something quite crazy because we make pain on pain to remove pain.
Yeah.
And at the end, when you count it, it depends on if you do it 2 weeks after, they are always happy, and one, or maybe not really, but at 1 month it's better, but at 6 months it's go back. And what is the part of the surgery, the part of the treatment, the part of the psychology, the part of the dietitian, the part of the vitamin? I don't know. At the end, nobody just give vitamin and go away.
It's just so complicated. But you know, the RCTs are supposed to take away that.
Yeah, you're right.
And we also know that from, you know, even the first RCT that was done in endometriosis was by our colleague who passed away last year, just down the road in Guildford, where Ben is a consultant, Professor Chris Sutton. And he did something that nowadays you couldn't get ethical approval to do. So he did sham laparoscopy in one group and then laser in the other group. So in one group, he did a laparoscopy, he found endometriosis, but he didn't do anything. And the other group, and in the group that he didn't do anything, 30% of them were better. You know, so we know that the pain of endometriosis, as you're correctly saying, is very complicated. You know, the placebo effect is real. But anyway, I guess we'll need more information.
Is the answer. You're right. Yes, it is the answer, especially when there is many.
Yes. And Flo, are we now ready for Dr. Philip?
Yes, I've made you host.
Okay, so Charles-Andre, I'm grateful for you taking the time. So we met a couple of months ago in Lyon. So I came to your hospital and we had a great time, and I really enjoyed working with you and the rest of the team. So I already know about this. I've also spoken to Professor Dubernat about this. I think it was in Brussels, if I'm not mistaken, or sorry, where was it in the recent years? Not Bordeaux. Marseille.
Marseille, maybe.
Yes. So I've already heard some of the results, but I'm really excited about this because this is something I'm interested in as well. I've looked at other forms of HIFU as we discussed, but I'm really interested in seeing what you found. So the floor is yours. Charles-Andre, by the way, you know, I don't know if Flo introduced you, but Dr. Philip is a great surgeon, a really good clinician, and works with Professor Dubernat in Lyon. And they've been working on this project HIFU, which is going to be really interesting. It may have it may change some of the things that we do in future. I don't know. We don't know, I guess, but we will hear the details from Charles-Andre.
So what he didn't say is that I'm one of the most French fan of Chahine. So I like his poster in my bedroom. And the second thing is that it's very, very nice to hear somebody you really admire telling such good things about you. So thank you,
thank you very much. I should tell the story about the pancreas, Charles-Andre.
maybe you can tell it at the end.
Yes, there's the story. I will share the story with you. I hope you don't mind.
There is also videos and pictures if you.
Yes. So I had gone to Lyon to share experience with the Lyon team, and usually when you go for these meetings and they share experience, the cases are, you know, simple cases, straightforward, because you want to get to know each other. I already knew Charles-André is a good surgeon. So that day was the first time in my life, and hopefully the last time, that I need to say, oh, careful of the pancreas, because this poor patient had a pancreatic and kidney transplant and a large uterus. But you guys did an amazing job, you know, got the pancreas off the, you know, uterus. I thought I'd seen it all. I
the pancreas of the uterus.
Yes, exactly. So I thought that I've seen all sorts of endometriosis and problems. I had not seen a pancreas stuck on the top of the uterus. But amazing. So the floor is yours. You carry on. I'm going to turn my
an introduction. I think nobody has something else to say. So we'll change of subject. I'm very glad, as you see, to be there. Thank you, Shane, and thank you, everybody. I'm so glad to present this presentation in the name of Gilles Dubernard, my former boss, and in the name of all of our team. You can see there is many names on these publications.
Philippe, we can't see your presentation.
We can see it? Okay. So.
If you're on the first page, I can see the first one.
Yeah, I was on the first one.
Yeah. I can see it.
I will try again. Okay. Can you see this one?
Yes.
Yes. Okay. I'm still on the first one with the title. And if I change like this, so you can see the second one.
Yes, perfect. Thank you.
Okay, perfect. Okay, so so there is a big group of people working on the clinical subject and more in the labs developing the subject. So it's clearly a teamwork. And so I will present you the result of our phase 2 clinical trial evaluating the safety of the HIFU, the high intensity focused ultrasounds, for the therapy of rectal endometriosis. That was a study on 60 patients that was not randomized, this one. So I have to disclose the same as my boss, to work with the EDAP company, which was created just near Lyon, and which is now a worldwide company where with the headquarters that have been translated to US now. And so what is HIFU? Like its name is telling it, it's focused ultrasounds, and it's classical ultrasound waves, the similar ultrasound wave by their frequency than those that you can use every day in consultation. It's the one we use is 3 megahertz. And there is two main differences. The one is that there is the waves are not parallel, but that they are focused. They will concentrate on a focal point, which is the target, which is the lesion you want to treat. And the second difference is the fact that at the source, the energy is very higher, which results in an energy at the target 10,000 superior to the energy that is developed by a classical diagnostic ultrasound. The advantage is that you can treat to a focal point which vary to 1 to 15 milliliters, depending on the source you use, and there is no effect at all on the cross tissue that you will cross to reach the source. That's almost magical. You can treat in the deeps without making lesion on the way. So that's the same way of saying the same thing, but there is two different way of making lesion with this kind of energy, HIFU, depending on how you will calibrate your device. You can use the classical thermical effect. The more you will use, the more time it will last, the more energy you will use, the more temperature you will put to the target. And you can also use a second aspect of the HIFU, which is called cavitation, is the fact that you can make boil your water by two different ways. Either you put heat source under your bowl and you wait that the temperature reach 100 degrees and then you have gasification, but you can also decrease the pressure. And when you use a ultrasound, a wavelength, there is a variation of pressure, and this variation is very high. When there is a big decrease of pressure, then there is also a gasification of the water that you can use if you want to make some kind of explosion inside the tissue. We don't use this one. We use more controlled thermic effects that will create coagulation necrosis early in the tissue, almost immediately, that you can see on this. I will just light on my this. So here you can look at a necrosis 2 days after the treatment, and with time the necrosis, like in surgery, like in natural way of degrading lesion, the necrosis will be replaced by a fibrotic tissue that will be responsible for some lesion that can stay in time on imaging. So I'm on two screen, not really. Nice. Up. So in our study, we wanted to evaluate the feasibility and then the safety of the HIFU treatment on rectal endometriosis. And after a feasibility phase 1 clinical trial, we made a phase 2 clinical trial where the primary objective was to assess the safety at 1, 3, and 6 months. And we included only patients with more than 25-year-olds without being operated previously by major abdominal surgery. And we have only one digestive endometriosis location. The point was to not being the result being pure on the fact that we were treating the only digestive lesion. The lesion has to be less than 15 centimeters from the anal margin, and the patient had to accept to keep the same treatment during the 6 months of follow-up and not attempting to be pregnant during the follow-up of the study because of the MRI that was a theoretical risk on early pregnancy. We also assessed clinical efficacy on clinical symptoms, gynecological and digestive symptoms, on the quality of life also. And we also assessed radiological efficacy and also global tolerance on analgesic consumations, the pain, the length of stay, and everything. So how does it work? That's maybe the most interesting. So the study was conducted on 4 different hospitals in Lyon, Bordeaux, in Horace-Roman, but also in Angers and in Paris. So how it works, I will use a little movie we made recently. So that's the probe. It's a big probe that consists of 2 transducers. One in the center, which is a diagnostic transducer, classical high frequency transducer, and a therapeutical treatment on the side. So the patient is on the side also, and the cervix is fixed with a grasper in order to fix the uterus and to decrease as much as possible the length between the nodule and the anal margin. Then we approach the device. We use motion sensor to stop everything if the patient is moving to avoid mistreatment. And then we insert the probe under the control of the eye of the surgeon. And you can see here the sonography, which is not in sagittal way, but transversal. And then you can see the lesion here, which is a little hypoechogenic lesion for the one that do sonography are used to. And you can also see there is a uterosacral ligament lesion in front that we can treat at the same time when it's visible. Then there is a treatment planification. The probe will automatically made volumic acquisition of the lesion, and then the lesion is made in slice. And in each slice, you will have to draw the limits of the lesions, slice after slice, until all the nodule has been delimited. And you can see here, the blue line is delimiting the lesion, and the blue dots are representing the future lesion we'll make. And then you press the start button, and the device is treating the lesion automatically, target by target, slice by slice, until all the nodule has been treated. There is a safety distance margin between the probe and the mucosa of the rectum is preserved by two-way, in fact, by the distance and also by the application of code inside the balloon around the probe. So you've seen the treatment, and it's almost as fast as the video is. In fact, you can see the in-out probe mean duration was 35 minutes in this procedure, even if 3 of the hospital participating in the study were not used to this procedure and never had tried it before. We were there with them, but it's really show you that it's very fast to use, and the operating the mean time in OR is only 1 hour 26 minutes in average, which is very, very lower than the time you have to use to make the same treatment in surgery. Which is interesting is that our lesions were 3 milliliter in average, which is quite big for endometriosis lesion. Obviously, 100% of our 60 patients had a rectal lesion, but which is interesting is that 93% of our patients had also a lesion of uterosacral ligament and or retrocervical space or vagina. And as you all know it, most of these lesions are the same lesion of the rectal lesion, so they are in continuity with the rectal lesion. And when it was visible and when it was possible, the lesion was also treated behind the rectum and as far as possible in order to treat as much of the lesion that we can. The treatment was feasible in spinal anesthesia, which was only done in 30% of the case because of complication I will talk to you just after that, and which chastened us a little. In terms of safety and tolerance, you can see that most of our patients were discharged after 1 day, mostly because there was an MRI planned at D1 in order to assess the immediate the post-operative effect on the lesion in terms of inflammations. But when this treatment is clearly feasible in an outpatient procedure for sure. You can say, which is demonstrated by this curve, which show the decrease of medication. You can see that only 45% of the patients were still taking painkillers after the treatment, and the mean or maybe the median of the pain at D8 was 0 in this population that is clearly of chronic pain patient usually. So that's something really interesting. And the work interruption was of 10 days, but I don't think it's really representative because we are used to give a lot of work interruption in France, in particular in medical study, because we were a little afraid of the risk of complication because it was the major objective of this study. So concerning the safety, we're happy to not to report even one Clavien grade 3 complication, and especially no rectovaginal fistula, no pelvic abscess, nothing very that could look like what is the everyday of the postoperative surgery of endometriosis. There was only one severe adverse event that occurred on a patient on the urinary aspect with an acute urinary retention that evaluated after on a chronic voiding dysfunction. But the expertise that, like, we stopped the study and we gather our independent expert committee that conclude that there was no relationship between this complication and the HIFU treatment, because in fact we were not really aware that before treatment there was a big lesions that went laterally and on the nerves, the hypogastric plexus, and also the patient had already on the MRI pre-therapeutic almost 1 liter of urine inside the bladder, and she already went to the toilet only once per day. So we changed our way of including patients, and we implemented the fact that we checked the bladder function with post-mictional residue and debimetry, I think that's the name. Every time we conducted the treatment, and during the rest of the study, we favored the general anesthesia because of this complication. But you can see in Horace Roman series of 2018 that Clavien grade 3 complications were mostly around 15%. So that's a good things for the safety of this procedure. And regarding the clinical efficacy, we were really impressed by the results. There was a big improvement on the gynecological symptom, with a significant improvement of acute pelvic pain, but also in dyspareunia. But it was also the case on most of our digestive symptoms, with a significant improvement of dyspareunia, diarrhea, constipation, falciuge, tenesmus, spasm, and dyschezia, and also on more general symptoms like posterior pelvic pain, and which is maybe a consequence on asthenia. These improvements were also translated on the clinical efficacy on quality of life, with a significant improvement of the SF-36 questionnaire in the many aspects of this questionnaire that were significant in almost all way. There was also, and it was the first time because our phase 1 study didn't reach this point, we show a radiological efficacy at 6 months, which were significant even after an independent and randomized review by an independent radiologist which showed that the thickness was decreased by 11% between before and after in average, and the volume was decreased by almost 30% with a tendency to the decrease in 77% of the patients, which and you can see on this example, which is not the case in all the patients, but you can see that here you had the lesions that was on the rectum and that was going on the vagina. At D1, you can see this gadolinium injected sequence T1, that there is a devascularized point with inflammation around, and 6 months after, you can see the vagina almost normal, and an anterior wall of the rectum that is almost normal also. So we are now to the conclusion. So the IFU show that it was a safe technique, and that was the major objective of this study. Probably safer than the surgery without any severe complications. No dysuria directly related to the technique, but I accept the discussion about that. No fistula, the pain was low, the medication level was short, and it seems to be efficient on digestive and gynecological symptoms and on quality of life, but also on the radiological follow-up. The cost effective is evident, even if we didn't had the cost study for now. And we already finished the inclusion and the treatment of the phase 3 randomized clinical trial, something that Shaheen would say would not be permitted in a developed country nowadays, because we made a sham treatment. And I will not tell you the result, even except if you ask me a lot. And we have planned to change some things. First, to adaptate the probe, because the probe was designed for prostatic cancer in a pelvic, in a malpelvic, which is not the same, and we have to go further inside the pelvic and in a different pelvic. So we try to develop a shorter, smaller probe to go higher, maybe to the sigmoid or to the rectosigmoid charnier, or the bifurcation. And we also have in mind to try to have the EU mark and the FDA approval during the year, this year, which is already began. So that's all of the team working with us in Croix-Rousse, working with us in the lab, and the team of EDAP TMS and our IFU baby, first baby. That's the way of making science in China, showing IFU baby more than study. And like the patients also, we don't have to forget that there is always some patients able to jump in from the plane with a new parachute, and so it's something very that have to be underscored. Okay, so imagine you have some questions.
Oh, we have so many questions. Thank you very much, Arlanda. So there are a few things that I think is fascinating. My interest in HIFU was mainly with the machine that you showed in your first slides, that the patient lies on her abdomen, and then
this one.
And I was, this one. And I was fascinated. I went and saw the machine in Oxford. We have one in Oxford here that is used for research mainly. It's not actually for clinical purposes. And we have managed one patient using this machine. My main interest was adenomyosis, because that was an area where you really don't have any other surgical alternative. You have a patient who wants to get pregnant, so you can't do a hysterectomy. and they have significant adenomyosis. And I really wanted to see if we can use this for adenomyosis. And in fact, in Asia, they have published quite a lot. So I was interested in bringing this into the practice, and we've managed to send one patient to that center. And I don't know what we can call a successful treatment, because what did happen was that, yes, there was lots of cavitation and necrosis in the areas that they've treated, but now we have sort of cystic structures within the uterus, and the fertility team can't be sure whether it's a good thing or a bad thing. And, you know, but apart from that, I have no question about the fact that with the HIFU that you showed, you are going to be able to shrink or even almost eliminate a rectal nodule. What I would be interested in your points about is, so do you think the rest of the endometriosis is less of a problem in the patient's symptomatology? How do you explain it? How do you explain the results?
That's interesting. You didn't begin by the normal first question. Like, you should have asked me, what did you observe in the other one? So I already told you that I'm a little dubitative about what we observed after the randomized controlled trial. That is what you said already, the gold standard. But to answer to your question, I would say you're right. The pain in endometriosis is really something complex. I would also say I would never take a patient with endometriosis and give her only one treatment without doing anything else. So obviously we put our HIFU in the middle of something. We choose to block the hormonal treatment in order not to make too many change around, but we manage the patient, and I think that can have an impact on the management and on the pain. And at the end, what I'm happy to see, and the only thing I stuck on, is in 77% of my patients, there is less lesion at the end than there was at the beginning. And that's what you can also have with the surgery. Obviously, in surgery, you have 0% of the thing you have removed, and the thing you'll have let remain or recur for sure. But you can accept that. But the surgery will never be the only thing you will do. And the question is, does HIFU is a treatment effective in rectal endometriosis? The second question is, is the HIFU better than the surgery? And the other question that we never have answer is the surgery a good treatment for endometriosis?
Can I add another question to that? Because I have a question that goes before all of this. Because the way I'm looking at your study and HIFU is that regardless of everything else, it may answer a very fundamental question. Because in no other study, we can treat only the rectal nodule and say we won't do anything to the rest of the endometriosis. Okay, so there will never be a randomized controlled trial that says we will do surgery, we will ignore the rest of the endometriosis, and we'll just go and remove the disease and see if the patient gets better. But with your study, we may be able to answer that question. Now,
you're right. And this question you ask is something that I would have loved to go around, because I always push to include only patients that have only, we can discuss on the only, a rectal nodule. I told you that for me, a rectal nodule that goes to the torus, the uterosacral ligament, retrocervical, the vagina, which is the same lesion that you can remove in one part, that is the same lesion. So I accepted that you can include these patients at the condition that we had to treat it the most as we can. The most as we can is sometimes all the lesion, and sometimes you let a part, but it's the same for the surgery, to be honest. So it's okay. And when there is small endometrioma, for example, in surgery, sometimes we look somewhere else and we don't touch the ovary. I think you do the same. So I try to always force my colleague to take patient that had only one lesion. So that's the answer, and that's what you can see if you look here. It's not the best way of showing result. I don't know if you use the Enzian classification every day, but there is, you see, there is only one. There is 4 patients that have more, or maybe 5. You can count 5 patients on 60 that have more than 3 centimeter endometrioma, and the rest is almost unique lesions of the rectum.
Posterior compartment. And
so that's answer to your question. I wanted something that can be revelative of those what we do is working, because for sure, if you have an endometrioma of 10 centimeters that is painful, you can do what you want on the rectum, it will remain the same. And the idea at the end is that we will use the HIFU maybe to treat a patient that have a low rectum nodule, and then after you can choose to do laparoscopy, or maybe you can do it in another way, but maybe a laparoscopy is more risky than the HIFU. And so I will begin with the HIFU one time, and if the patient is happy, we stop there. And if the patient is not happy, we can try to do a simpler surgery after that. Yeah, that's the way we see it.
Look, I think the first thing that I'm really impressed by is I can only imagine how difficult it would have been to organize, coordinate, recruit, execute a study like this. You know, it would have been really difficult to convince the people who are decision makers that, you know, let's try this. And as I said, regardless of whether, I don't know, in 3 years' time, I will have to now go and sit at home and don't do any surgery because HIFU has taken my job, or whether, you know, we'll see that, okay, it is another tool in our toolbox and maybe we'll use it for some patients, which I think is the more likely scenario. I think your study has the potential to answer some fundamental questions, because if you show that by treating the rectal nodule, even without treating the rest of the endometriosis in the pelvis, in the pelvic side wall, in the superficial endometriosis that will be all over the pelvis in many of these patients, you are reaching the same sort of results that a surgery that completely excises all of the disease will achieve. I would then go back to asking the fundamental question of where is the pain of endometriosis coming from? What is the main cause of the pain? And I think that is a very, very challenging question to answer.
That's very challenging because it goes in every direction. You try to answer what you are just pointing by your finger, because I would say the pain comes from the nerves.
Yes. Yes.
I would tell you the nerves are very sensitive to the heat. So maybe we just treat the nerves. Maybe we just kill the nerves inside the lesions. That's what we were thinking when we tried the first clinical trial on 23 patients, and we observed an extraordinary clinical effect without any radiological effect. It was either totally a placebo effect, or the patient were to be understood, and then it was something very effective without any radiological effect. That's interesting because that's always what that is been reported by the study on HIFU, on myoma, on adenomyosis, on everything. There is small change on the image, but big change on the symptoms. You treat a myoma, the patient stopped to bleed, she stopped to be painful, but the myoma just changed a little. And so that's interesting. But to answer your other questions on the adenomyosis, I'm just questioning myself because the muscle is really sensitive to the heat. So you will always make big damage in the uterus. At the same time, you will do on the endometriosis and adenomyosis. It's interesting because on lab test we made, we observed that endometriosis has a high acoustic attractivity, so it kept the ultrasound higher than normal digestive wall. So if you put the same amounts in the rectum that you use to treat the endometriosis, the effect will be bigger on the endometriosis than on the normal rectal wall, which is interesting. So that's part of the answer. But what I know, and I will answer to the question you didn't ask me, is two things. We compare with Horace what we obtain with HIFU and what he obtained with his surgery. And the results in terms of quality of life is better after HIFU than after surgery. And more when you have vaginal resection. So, and the second thing you didn't ask me is the result of the RCT is there is difference between before and after in every patient, but it is true in the patient treated, but also in the patient in the shame group. It's probably the radiological effect is clearly higher and significantly higher in the treated group than in the shame group. But if you put all that together, you ask not yourself, is the HIFU is not as good as the surgery, but if the surgery is really good at all. And that's really like being at the top of a big mountain and looking down in the valley when you say that, and we are surgeons, you tell it to everybody at the beginning. I like the surgery, and I only go to this treatment with Dr. Dubernard because I don't like to do surgery on patients having nodules at 9 centimeters from the anal margin stuck to the vagina. And I knew that after that, it's always risky, and I prefer to remove a small lesion of the sigmoid and a small lesion of the uterosacral ligament. And
so my last question: when are we expected to see the result of the latest study?
We just finished because what I didn't say is that we made the randomization, and we agreed with the patient previously that if they were in the shame group, they will be offered a treatment. And we followed also these 60 patients. So for these 30 patients. So we have treated 60 patients, and we just finished to follow the 6 months after the patient that have been treated after the open label. So we will now publish the results in the next month.
Thank you very much. So we are 5 minutes, 6 minutes over time. I just want to thank you very much, Charles-André, and please give my regards to Professor Dubernard as well. Thank you very much, Flo and Ben and Charlie, for running this, and sorry for being late. I will see you all on the 6th of next month at 6 p.m. UK time.